Hello, I'm Peter Norton. On behalf of Henry Schein, thanks for tuning in once again to ScheinTV. For this episode, we're going to talk about the sort of daily dental dilemmas that make up the majority of the care that we provide for our patients. Our discussion will be very nuts and bolts on a topic that you can apply to your practice tomorrow. Shortly, we'll have a real patient in the chair, and we invite you to become part of our dental team for the night by sending us your questions, comments and observations during the treatment. We're joined once again for this episode by Professor Ian Myers. Welcome back.
Thanks, Peter. It's great to be here.
Thanks again for for being willing to treat a patient in the chair. I mean, we all know how useful it is to see real treatments in real time rather than photoshopped ideal cases.
Yeah, look, there's no hiding tonight. We'll show you a couple of procedures and show how things can happen in real time.
Looking forward to it. Our event this evening is scheduled to run for approximately 1 hour. As always, we encourage you to interact with us by sending us your questions and comments. In order to do that, please take out your smartphone right now, open the browser on your phone and go to Schein.tv. Once you've done that, click connect and you can send us as many questions as you like. We'll get to as many questions as time allows. By joining us here this evening, you're eligible to claim 1 hour of scientific CPD. At the end of the event, we'll give you instructions on how to register for your CPD certificate. But before we get started, let me tell you a bit about this evening's guest. Prof Myers holds honorary positions with the University of Queensland and James Cook University. A former Chief Dental Officer for Queensland and past President of ADAQ, Prof Myers is also a past Chairman of the ADA's Dental Instruments, Materials and Equipment Committee, and also consults to a range of dental companies on their products. With all of that, Prof Myers still finds time to maintain a private dental practice. So Prof, I think it was Bill Gates who once said that treatment without prevention is unsustainable. What are your thoughts?
Yeah, I totally agree, Peter. I think that we often think that we can do a set procedure on everybody and you're going to have the same result all the time without considering the oral environment it's going in. It's really important to make sure that we choose the right procedure for the right patient. Too often we end up redoing restorations or redoing procedures because we haven't selected the right patient. So hopefully we'll talk a bit about that tonight, and I've got a little presentation I wouldn't mind going through just to highlight a few of those issues, and then we'll get on to treating some patient.
Great.
So what I want to talk about mainly tonight is how we manage a lot of what we'd say and call our daily procedures. It's not so much the complexities of dentistry, it can be some of the things you see every day which can be a little bit more confronting. And really it's more than just doing restorations. You've got to look at why has the patient got to this state anyway. You can see some restorations here which obviously haven't been successful, they've failed again. And you've got areas up here where there's been fracture and decay. And you've got to think, maybe I should have done something differently here. We look at a range of different risks with patients over time, and I think that we've got to realise that through a patient's lifetime there are different risks that they come across, and so that means that the things that we want to assess and diagnose in those times needs to be different. Certainly what we get in our very young children with possibly some early childhood caries, and there's effects, what the parents do with them. They go through these mixed dentition stages where they can have quite crowded teeth. It can be difficult to keep things clean. And then they get into the teenage years where diet becomes an issue, hormones kick in, there's often orthodontics there, so there's a different set of risks here. And then as they get a bit older, they start to become a little bit more independent. They all sort of start to possibly have families, go to university, have all sorts of issues there. And so there's a little bit of an issue in terms of what's going to be most important to those patients. And I think as we go through the different age groups, as they get older and older, we see some completely different aspects occurring. I think as they're getting into the older age groups, then you start to get the same problems. We're getting patients keeping their teeth a lot longer now, and certainly in the sort of 50 to 70, the 70 to 80 age group, medications come in, dry mouth gets in there, and then people are living into their 80s and 90s with a lot of their own teeth. The dry mouth, root surface caries, medication risks become a problem, so we need to think more about where we're going. So, to avoid having these disasters, we've got to think, well, what can we do early on to prevent this from happening? And, we've also got to think about how do we deal with some of these difficulties that we face in practice. I mean, you've got lots of root surface caries, broken down teeth. They're not easy things to fix. And patients expect us to be able to fix these, and maybe our conventional crowns aren't particularly good, because once you put crowns on teeth and you get root surface caries, these become very difficult to restore again. So I think there's a couple of aspects I want to highlight tonight. I want to look at how we manage the current problem with some of our ageing patients. I want to look at how we prepare some of the sort of recently old, as I'd call them, for their advancing age. And then the younger generations, how do we get them into the mindset of how we can keep them keeping their teeth for longer? Because the 70 people only living to 70 no longer exists. And people want their teeth at 70, 80, 90 years of age. And certainly what we do now is going to impact on future care. So I don't really want to see the complexities of the bad caries later on in older age groups. If we can catch it early, it's going to be better. But I think one of the things that we have, unfortunately, in dentistry is people don't really think about that. We're so focused on doing restorations, and whether you're in a public sector or a private clinic, it's usually we're being rewarded for doing a procedure rather than preventing disease. Unfortunately, we're not that good at trying to prevent disease, and we don't get rewarded for preventing disease. So people get to the concept that prevention isn't really profitable, and it may not even be possible. And certainly the concept of prevention isn't sexy is out there, and how do you sell it to your patients? And now we're talking about the issue of MI as being the new way of dentistry, but MI, people often say to me, oh, it's just a new term for prevention, there's no point, it doesn't work, patients don't listen. But I think we need to embrace it a lot more. I think we need to look at how we can make this work a lot better. And I think that one of the things that really hits me, and as you can see on this sort of slide here, we all get older, our teeth get longer, that's where the saying comes from, you get a bit of recession, you get long in the tooth. What are we going to do to treat that? And the current group of patients, I think we know that we can protect it with some remineralisation. You can even use varnishes to protect it. And it's possible to even do surface sealing. And I'm going to sort of talk about those three issues mainly tonight. And then look at a bit of the younger population as well. But I want to point this case out just quickly. You can see here that there's some caries on the screen. And these teeth are in a patient who's in her 80s. She's had some crowns which have been doing great for a long time, but all of a sudden she's not able to clean them as well. She's got dry mouth from some medications. And now you've got this root caries setting in. And unfortunately, this root caries was so severe on those two centrals that those teeth could not be salvaged and had to be extracted. But what do we do for the other areas of recession which could be root caries? What do we do for those? In this case, I've done some surface sealing with some Fuji 7 and some Fuji 9 extra there to try and protect those surfaces rather than cut the tooth structure away. I think if you start cutting that away, you're going to ring bark it. So it's not about redoing the crowns, because I don't think there'd be enough tooth structure left to do that. We could go in and use some of our remineralisation strategies, and I think they're great as an augment to that as well. So what I'm trying to do in this particular case is you'll see that there's some dry mouth up the top there. After we've sort of got onto some dry mouth gel and use of tooth mousse, we've actually managed to get the patient looking a lot more comfortable. You can actually see an increase in hydration there. It looks a lot more comfortable and much easier for the patient to look after that, so that then when we give the dentures that they need to replace that gap, that we can use our dry mouth gel not only to lubricate the mouth but as a adhesive for the denture. If you've got a dry mouth, we know the denture's not going to sit there, but by putting a little bit of gel around the dry mouth, a little bit of that dry mouth gel around the denture, it helps hold it in place.
You mentioned Fuji 9. With the current range of GICs that are available, would you still go for Fuji 9 Extra, or would you use one of the newer materials?
I think it depends what I'm looking for in terms of the outcome. I like the Fuji 9 because it's aesthetic and it's got a reasonably high fluoride, but we do have some great materials now. For example, the Equia Fort Fill is now coming out as being less soluble but releasing a little bit more fluoride. So I'm probably going to move towards the Equia Fort Fill now for those cases. I'm still sticking with the Fuji 7 for some of the high fluoride release because I know it's going to release even more fluoride. So it depends whether I'm looking for aesthetics or if I'm looking for higher fluoride release, or strength is the other issue. And I'll touch on that a little bit later when we talk about some of the other materials. I mentioned the Fuji 7. I think it's a great product. I use it a lot, and I use it not just as caries control, but also a marker for the oral environment. And in this series of slides, you'll note that initially there's some severe root caries which I've restored. But then down the bottom here at 3 and 6 months, you can see that the material seems to be disappearing. And it is, it's dissolving away because the glass ionomers will dissolve in an acid environment. But what this is telling me is that the patient's still got some risk factors there. There's still acids there. And if I'd restored this with composite or some other material, more likely there would have been caries around the composites. So to me, I'm looking at a stabilisation phase here to try and get it a bit more stable for the patient. You don't know when that's going to be better. Sometimes it could be that it takes a bit long for that stabilisation to occur and you keep redoing the glass ionomers until they become stable. Sometimes they stay with that forever. But certainly I think you need to consider what is the risks currently with the patient and then long term.
How do you talk to your patients about that at the beginning? Do you say, look, there's a good chance this is going to be an ongoing story? Or?
Yeah, it's difficult because quite often I say we're going to restore this as an interim treatment, try and stabilise your mouth and then come back later on and put a more permanent filling in. And they sort of think, well, hang on, I don't want it filled twice. What do you mean? And you've got to talk to them. It's about disease control first and then moving to the permanent restoration once you've controlled the disease. Unfortunately, some of the older patients on a range of medications with dry mouth, it can be very difficult to get the perfect ideal no risk But I talk to them about, everybody's different, everybody's got different risks, and once they understand the factors that they've got to be aware of, it makes them easier for them to understand why I'm choosing that treatment. I think patients really like the concept that you're explaining, that you're individualising the treatment and not just popping it off the shelf and using it simply to fill a tooth, because we're a lot more in that. We're a biological approach to dentistry these days. So let's move back a step, and I want to talk a little bit about preventing things. I mean, I talked a little bit about the older patients there, but I think if we can get in early, the upstream approach is always better. If you can stop the disease earlier, it's going to be better than trying to treat it later. So the fluoride varnishes, I think there's plenty of evidence to show they work well, and there's huge reductions in caries if you use fluoride varnishes, both in primary and permanent teeth. Cochrane database review shows it. There's been studies over in other parts of the world. This is out of Canada, and there's even one in Northern Territory which showed that there was a reduction of 3 decayed surfaces per child by placing varnish on the teeth twice a year. And so it's quite significant that the application of fluoride varnish in reducing caries in children.
Was that study done in conjunction with prophylaxis or anything, or was it?
Look, it was done in some Indigenous remote communities in Northern Territory, and the only intervention was they were seen twice a year. Yes, there would have been some prophylaxis, there would have been some other things as well, but when you took all of the variables together, it appeared that those that had the fluoride treatment versus those that didn't ended up with a lower level of caries in the long term. So I think that there's some fairly good solid evidence there, as is shown by the Cochrane database review, that fluoride applications definitely do work in terms of caries. But I want to go one more than that. I mean, yes, it's stopping caries, but there's other things that fluoride varnish can do as well. And there's been some big changes with fluoride varnishes too, because they're not just fluoride anymore. Most of them are 5% sodium fluoride. But now there's the addition of various forms of calcium to those. So whether it's amorphous calcium phosphate, whether it's tricalcium phosphate, or the CPP-ACP, the Recaldent type product, they're really all about trying to get calcium and fluoride into the patient's mouth, because we know that apart from the caries reduction, that remineralisation and protection of the tooth is very much calcium dependent. So when patients that are younger or older that might have a depletion in available calcium, this is where there's going to be a benefit. And it's also, as this study shows, and this is in the Australian Dental Journal a couple of years ago, it talked about the fact that the varnishes should release their ions very rapidly. There's no point having them sit there. I mean, the varnish is really only going to stay in the mouth for 24 hours or so before it gets washed away.
So it needs to get the job done in that time.
So it's got to get those ions out pretty quickly. It's got to strengthen the tooth structure, absorb into restorative materials that are there, and protect the teeth in that very short time. And I think the real benefit is that when you add calcium into tooth structure, calcium into the varnishes, that it actually not only strengthens the surface protection, but you can actually get calcium fluoride formation in dentine tubules. So yes, you have one thing about remineralisation of enamel and dentine, but there's also the desensitisation aspect. And I think many of us as dentists use varnishes as a treatment for desensitisation. So we've got the caries control with the varnish, but you've also got the desensitisation issue. So where do we go to from here? Well, there's lots of different varnishes about. Many people will be aware of the standard Durafat. It's a very common name and people have used that for many years. It often became unpopular because it was quite a dark colour. They went to a paler colour, and now it's available in a white single dose. We also have the MI varnish, that contains the CPP-ACP, and the white varnish, Clinpro white varnish from 3M, which is the functionalised tricalcium phosphate. And people sort of say this, and I often say to my patients, I'm putting a band-aid on your tooth, because in essence we're doing that, we're covering up the dentine tubules, and that sort of makes them less sensitive. But as many people will be aware that as soon as that washes away, the teeth get sensitive again. So it's more than just placing the varnish. You've got to think, why are they sensitive? Is there some way I can make it stay on the tooth a bit longer? Can I actually make it penetrate deeper and be stronger? And that's where the calcium inclusion is really helping now. So there's nothing wrong with using the straight fluoride varnishes, but I think if you're looking at both remineralisation and desensitisation and it's staying on the tooth longer, then there's some big chances for these products to work.
We have a question about how often we should use MI varnish in our patients. What are your thoughts?
Yeah, look, as I said, those studies show that twice yearly applications can create a reduction in caries. I think it depends on the risk of the patient. A lot of my patients I see every 3 months, and the Cochrane database talks about 2 to 4 yearly applications to really get the big reductions in caries. Now, obviously, this is a boost effect. You're creating these peaks in the fluoride application, but you've also got to look at the day-to-day things that you do. You're not going to be putting a fluoride varnish on every day, so you're going to be using some things like normal daily toothbrushing with a fluoride toothpaste. It may be you need a higher level with some of the high concentration fluoride toothpaste, or even some of the remineralisation agents like the tooth mousse or other areas of that. So it's not just that, you need to augment it as well. But my feeling is high-risk patients 4 times a year, every 3 months, standard protection twice a year.
And would you be doing a full clean, a full prophylaxis at each of those appointments, or just
Yeah,
perhaps
look,
twice
normally I do the clean to reduce the biofilm, and people like to have a clean feeling mouth and they like the concept of then having the application. I don't use any form of tray application fluoride anymore. My applications are via direct placement of varnish. I feel it's far more efficient than using trays and liquids and gels. You don't have to do the prophy because you can actually enhance the biofilm with the fluorides, but personally I always do a prophylaxis first. So other products, we talked about the 3-in-white varnish, functionalised tricalcium phosphate. Certainly the GCMI varnish is one of my favourites because I know the effect that the CPP-ACP has in enhancing remineralisation. There's plenty of data on that. And if you look at the data that GC have provided me with, it actually does release quite a bit of calcium there as well. So particularly in older patients that may have dry mouth, where there may not be the calcium in the saliva, this might be a big benefit for them as well. But the big thing is you also get a stronger penetration into those tubules, and it actually makes the material last longer. The other really interesting thing with that, those varnishes is that when is the fluoride released? And that study that was done by the late Nathan Cochrane and colleagues in Melbourne came up with some very interesting data. And this is a time period through to a week, but the grey bar is the one I'm really interested in here, the one that shows what happens at 1 day. Because that's when you want most of it released. Most of those ions out there and effective very, very quickly. Because then we know that at that 24-hour period, that's the point in time where you've had the most benefit to the surrounding tooth structure. The other thing is, if it can stay there longer, that's great. And that article also looked at the solubility of the varnishes and how well they stay on the tooth. And one of the things they showed is that, yes, they all break down over time. And even though generally you only think of 24 hours, some of them are there a week later. So there's the potential for some of these to stay a lot longer than we originally think.
And what's the sign of breakdown according to those photos?
Well, this is basically done on a little PVC film, and they place it in water and they let it wash away, and the little bubbles that are forming there just so that the resin and the rosin that holds it onto the tooth starts to break down and bubble away. The less bubbles that you've got, obviously the stronger it's going to be. Clinically, it's very hard to see this, and I have to say that we often place a varnish on a tooth and you can actually see it almost peel off before the patient's walked out of the chair. That usually means you've placed too much on the tooth. We clinically can't see a lot of these varnishes 24 hours or 48 hours or a week later, but there will be residual elements, if not on the tooth surface, if it's dentine, inside those dentine tubules. So I suppose this image really shows what happens. We're trying to get the varnish onto the tooth structure. It should penetrate down dentine tubules and it should stay there. And that's certainly going to increase its benefit as a desensitising agent. And by doing so, it also is going to protect against caries and erosion, because you've got something which is a barrier not just on the surface but also deeper into that tooth structure. Obviously enamel's slightly different. I'm focusing more on dentine here, but we know that to remineralise enamel is one thing, but I think a lot of people are looking at the dentine issue and the hypersensitivity. So how do we apply this stuff? I mean, this is not rocket science, but I think there is a bit of interest in this because people are doing this wrong a lot of the time. I think varnishes are often slathered on way too thickly. Unfortunately, even the manufacturers have used this image here, which is, I think, totally incorrect. It's way too much of this material here. This MI varnish here, and this is the strawberry flavour. They have a strawberry and a mint flavour, but it's 0.5 mils. To be honest, it's a lot. I probably only would use maybe a tenth of that.
And that's on an adult patient?
And that's on an adult patient, because I paint this on very thinly. In terms of dosage, I would never use more than half of that on a child. About 0.25 mils of this would be the about maximum I'd want to use if I'm doing a full fluoride treatment. But often I'm only doing 2 or 3 teeth. I'm not doing the whole mouth. And just because it's there doesn't mean I have to use the whole lot. Now, people often say, oh, I bought this, I want to use the whole lot. But I just use the analogy of, if you're doing a small procedure with some local anaesthetic and you only need, half a mil, you don't inject the rest of it simply because it's there. I think that you only use what you need, and it's not that, it's all about patient care there. So I think, unfortunately, once you open this and use it, because it's got an ethanol solvent, it does evaporate fairly quickly. What I would suggest we do is keep it thin. And a lovely analogy I received, and this came from the CEO of Henry Schein Ellis, Mike Covey, that said, it's a bit like Vegemite. A little bit goes a long way, and that's exactly right. And I think that's a great take-home message, because, you put it on too thick, it maybe is not everybody's palate, and it probably ruins what's underneath it. But you need to paint it on, and it needs to be painted on very thinly. And And by doing that, you actually still create the coating. The excess material is just going to wash away. It coagulates up, and most of these varnishes will set on contact with water, and if you get too much of it there, it just peels off the tooth. So the thinner coatings tend to be slightly better. There's a lot of things about the application. When we get to the patient treatment, I'll talk a bit more about that, but there are a few things. I mean, do I use it on crowns and veneers? Obviously, it's not going to remineralise metal, but around the margins, it's particularly good after cementation and longer term to prevent that marginal breakdown in caries. Yes, you don't have to do the prophylaxis as we discussed, but in my hands, I think it works better. One of the other things on that was that, can I use it on patients who've got milk allergies? Really, it does have the CBP-ACP protein, the casein protein, so no, you wouldn't use it on patients with milk allergies. And are there any other contraindications? Well, not really, but the material can get a bit sticky. So if you've got someone that's got a mucositis or ulceration, quite often the tissues may stick to it, and that can be a bit uncomfortable. The way I get around that is to just moisten it after I've placed it, and that makes it very slippery and slimy afterwards. But some of these new varnishes are aimed to stick on the teeth very well, and they can feel quite sticky to the tongue and patient. So, varnishes, we've talked a lot about those, but I think we can move to the next level, which is if you want a varnish which lasts a bit longer or longer term fluoride protection, and then we move into the concept of surface protection. And this is the idea of using a glass ionomer or resin modified glass ionomer as some sort of root surface protection which isn't going to wash off within 24 hours, is going to be there a bit longer. And this was always thought of as a restoration, but it's really not a restoration. This is more about just creating a very thin layer of a restorative material, in this case some glass ionomer, over the top. My favourite material for this is the Fuji 7 and more recently Fuji 7 EP. And people sort of say, well, how do you classify this as a treatment? And I don't want to get into treatment codes, but it's now listed in our schedule of dental services as fissure and or tooth surface sealing, which is at item code 161. And whether it's fissure protection on the newly erupting molar or whether it's on these buccal lesions, it's still one of those treatments. You may not be aware, but the Fuji 7 EP has come out and it's got the 3% CBP-ACP in it. And again, it's this inclusion of the calcium, which is the big plus here. And it's helping the remineralisation strategy and pushing it that bit further. So this has become one of my very popular products. It is available in both pink and white, and people often say, oh, it doesn't look very aesthetic. But from my perspective, it's all about telling the patient, this is an area you need to be aware of and keep clean and look after. So it's a bit like a marker for where we need to have a bit more activity in cleaning.
Going back to a slide a second ago that showed the dentine conditioning, it's just relating to a question from earlier. Do you condition every time before placing a GIC?
Look, I think it depends a little bit on sensitivity. If a patient's extremely sensitive, it usually means there's some acid attack and it's probably lost the smear layer anyway, because in essence, sensitivity in dentine will be more evident once you've lost that smear layer. We all know that some areas of recession and exposed root surface aren't sensitive, and it usually means you've got some form of smear layer over that. And those are the ones, if they're not sensitive, I would definitely do some conditioning. If they're very sensitive, which means they've probably lost some of that smear layer, I may not condition. But as a general rule, always do a cleaning with a non-fluoride containing or pumice type material just to clean the surface. If you feel there's a need to remove a smear layer, then use the conditioner. I just use cavity conditioner, 20% for 10 seconds, and then place the glass ionomer, same as any other product. So, if we then move on and have a look at the patients that are long in the tooth and how we do this procedure, it's not a restoration. This is a very thin layer, and again, it's like painting onto the surface. We're just going to paint a very thin layer of the material over the surface to try and give you some protection. Obviously, there's going to be areas here which there's not a lot of room to place a restoration, or if you do, you may irritate the gingiva and get some marginal irritation. But if you can paint a very thin layer over that and then cover that with some more fluoride varnish, you end up with almost like a double protection. You've got the glass ionomer underneath and then the fluoride varnish on top. So you're getting this immediate desensitisation, but the longer term fluoride release to the adjacent tooth structure. And I quite like this brochure which you've just come out from GC about root surface protection, and they've got this concept of brushing up on your skills, because I think that's the concept we need to get in our minds a bit more here. The idea of we're not restoring the tooth, we're simply putting a thin layer over the surface to protect it and try and stop it being sensitive, but also combat further breakdown. So, we've talked about a few things. The question is what to use where. We're always stuck here. I haven't answered any questions yet, and when we get to our patient, I'm going to sort of go through this, but I've got to think, how easy is it to place this? Do I want to cut away tooth structure? Do I want to leave it? The non-carious, lesions, we obviously don't want to cut away if we can avoid it. Is aesthetics a major concern? Do we want something that's going to be resilient? Is it going to be economic for both the patient? Is it going to be economic for the practice? So we've got to look at all these things as we're going along, and I'll sort of go through that. And I think one of the things is, do we have the universal treatment? I don't think so, and we'll cover on that in a minute.
If you've just joined us and want to submit a question, take out your smartphone, open your browser on the smartphone and go to Schein.tv. Then click connect and you can send us your questions.
So, can we use one treatment fits all? And I would have to say, absolutely not. Because at present, we don't have that universal material. All patients are different. Their mouths are different. Their teeth and situations are the same, and their lifestyles are different. So we need to consider each of those. But we've got some great options out there. I mean, you've got to look at the age of the patient, oral hygiene, caries risk, tooth wear risk, what previous treatments may or may not have been done, what's their salivary status like, what's their current risk, and what's their potential future risk. It's not something we think of much, but we need to get back into that and think, how can we actually prevent these sort of things from happening? You also need to think about the quality of the tooth structure, and we often forget that. We think, oh, enamel's enamel and dentine's dentine, but it can vary a lot. I mean, there's a lot of difference between demineralised and hyperplastic tooth structure compared to fairly standard sound enamel. And whether it's deciduous or permanent, whether it's cut or uncut, we talk about these things with adhesion, but it's also about what are we going to do about remineralisation. And then with dentine, there's a big difference between younger and older patients. Has it become sclerotic? And how close you are to the pulp? How deep is that lesion of wear? Is it a very deep lesion or not? And is there the smear layer, as already mentioned? So I think there's a couple of things we need to consider. It's very difficult to know whether you're remineralising enamel or whether you're trying to remineralise or desensitise dentine, but you need to think a little bit about that structure. You need to think about individual cases, and don't just every time a patient comes in with some exposed root surfaces say, I treat everything with varnish or I treat everything with a restoration. We need to be a little bit more specific on where we're going. And I also think you need to be aware of, is it going to be that permanent restoration at day one? And I started with this comment about the fact that if you place restorations on an unsound tooth, you're going to have failures. And so this idea of prevention early and getting in and restoring, I mean, these lower two images down the bottom on the screen here, you'll see that you've got caries here, but when you remove the caries, you've got these margins which are very demineralised. I'm not going to restore that with a composite because nothing's going to bond to that. I'd rather try and remineralise that. So initially I'm going to be placing a glass ionomer in there, improving the patient's oral hygiene, remineralising that so that later on we can go in and put the permanent restoration, just as we did with that older patient with the root caries.
How would you feel in that case about perhaps using a composite that's bonded using, for example, Fujibond LC?
Yeah, look, I think that you're moving into a better zone. If you have to do it on day one, you need to use something which is glass ionomer based to bond to demineralised tooth structure. We know that bonding direct resins to demineralised tooth structure, whether it's hyperplastic tooth structure or whether it's demineralised, is not going to be successful. You get failure of the substrate, not failure of the adhesion. One of the advantages using glass ionomer based products is you will get some chemical adhesion, even to slightly or broken down or demineralised tooth structure. Because the other alternative is to keep ring barking the tooth, and you try and cut away that demineralised tooth structure and you end up with nothing left. So I think we need to be a bit more conservative. So we're going to move on to our patient in a minute, but I thought I'd summarise this by saying that, look, we need to think that our general conservative dentistry really is failing to address why things fail. We don't want to get into this repeat restoration cycle because we then think, well, hang on, what's going wrong? Is it my fault, or is it something I'm doing wrong with my materials and techniques? Where quite often it's the fact that the disease control hasn't occurred, so the prevention hasn't been there. We need to have that biological approach, as mentioned in this slide here. We need to look at management of dental caries. We need to alter diet and lifestyle. We need to look at our new materials and techniques and think about how we're going. So this particular case shows a very simple area of demineralisation, placing my cavity conditioner, making sure the tooth surface is clean, placing some glass ionomer and then varnish over the top. We know that we cover our glass ionomers early, and there's all sorts of reasons we cover them to prevent moisture contamination, and we can use Vaseline people use, some people use bonding agent. I think the varnishes are great because you're getting the benefit of the fluoride plus also the protection of that material. Not in every case, you've got to think about which one's best. So I think we've talked enough. Let's move on and do a bit of a patient case.
Sounds good.
This is Sam. I was given these photos some time ago about Sam, and he had some of these lesions. And we're going to focus today on these buccal lesions on the left-hand side here. I think you can see clearly there's some lesions there. He initially presented with a lot of sensitivity, and his treating dentist did a lot of good work, and a small restoration was placed on this premolar here. So we're going to look at this today and look at these lesions because he's still getting a bit of sensitivity, and the restoration didn't appear to do exactly what it aimed to do at. So we might move on and have a look at Sam and see how he's going.
Well, while we move on to that, we have some questions here. What are your thoughts in terms of MI varnish or similar products for pregnant women, particularly given that a lot of people seem to think that their teeth get very weak during pregnancy?
Yeah, look, there's a bit of a sometimes an old wives' tale about that. There certainly are hormonal changes in pregnancy. We do know that there can be changes in saliva. It has been shown you can get a slight increase in acidity during pregnancy, and so they are slightly more at risk. But the old story of you lose a tooth with every child is not true. Okay, it is about prevention. I think it's an ideal adjunct any time the risk increases. And that risk might be to do with pregnancy. It might be to do with the fact that they're going through their teenage hormonal years. It could be menopause. It could be all sorts of hormonal changes. It might be related to the orthodontic brackets they've got on. Again, it's the risk patients we need to do this more. Yes, you can do it routinely for some patients, but it's also making sure you target those high-risk patients. All right, so Sam here. How are you today, Sam? All right?
Good, thanks.
That's great. Thanks for being patient and waiting for us. I'm just going to get all geared up and we'll have a look at your teeth and see what's going on.
Sure.
So keep those questions rolling in. I think that'd be good too.
Absolutely. If you have just joined us and want to send a question, take your smartphone out, open your browser on your smartphone and go to Schein.tv. Click connect and then you can send us as many questions as you like. We've also had a question about what's the difference between MI varnish and its CPP, ACP, and simply just asking a patient to drink non-sugared milk after brushing with a fluoride toothpaste.
Yeah, look, I think the same thing's been said about possibly eating a piece of cheese rather than having it. There's all sorts of reasons about where we want to get the natural. Look, it's not as available. It's obviously not in a concentrated form, so the tooth mousse and the varnishes are going to be a lot more directed to where you want to put it there. Having your glass of milk or your piece of cheese, yes, it might have some benefit, but you've got to weigh up the fact there's probably some fats and other things in there that you don't want to be having it all the time. This is a directed treatment. I certainly think there are no problems with having milk, calcium-based products, but I would think that if you're looking at a targeted approach, it's more about placing it where it's needed rather than the systematic approach of drinking a whole lot of it.
And I would imagine doing that just after brushing your teeth, you'd be a little bit worried about the lactose content, or not too much?
Yeah, look, I mean, sugars in everything have got an issue, and I wouldn't want to be putting a lot of lactose and fermentable sugars around the teeth. So, yeah, I would not agree with that. Yeah.
Good-o.
All right, so Sam, let's go have a look at your teeth now. We'll see what's going on. Now, Sam, I know that you've had some sensitivity for quite a few years now, and we're going to have a little look at seeing what's going on. We're going to be looking on this left-hand side where you've got some of these lesions. To make it a bit easier to have a look at this, I'm going to put a little retractor inside your lips here, okay? Just going to use one of these little Optrogates here and just pop this in. I might just moisten this a bit just so it's not too difficult to put in your mouth. So this is just going to slide in the corner of your mouth and we'll just pop this around and just isolate these teeth there. That's great. You okay with that, Sam? Comfortable?
Yeah.
That's great. All right, so let's have a look and see what we've got happening here. So you turn towards me just a fraction there, that's great. So I think we can see quite clearly that there's some quite significant lesions along the side of the tooth here. There's even something on the lateral, canine. That's the premolar, the T4 that's been restored on the buccal. T5 and T6 are also showing a little bit of a lesion there. I might have a little look and see how we're going with sensitivity on these. I'm just touching these gently. That's not too sore anywhere there, Sam? That's good. I'm just going to blow a little bit of air along here. Just tell me if there's anything that's uncomfortable at all. Just some little light air here. Not too sensitive there? That's good. Oh, a bit of sensitivity there. I can see you jump at that one. A little bit there as well. Okay, so we've got a couple of sensitive areas with these teeth. So now it comes down to working out what we might be wanting to do with each of these individual teeth. Looking at this, I probably wouldn't restore this lateral because there was no sensitivity there, but we need to talk about why this has occurred. We need to think about why we've had all these lesions, and there's all sorts of reasons why this might occur. My original teaching was all about it's got something to do with brushing, and it could have been that if you're right-handed and on the left-hand side you scrub in one direction, it's going to wear the teeth away. Then there was another theory that if you sleep on that left-hand side and you have some acid reflux at night, you get accumulation along that side and it might end up with some dissolution. And then, of course, there's the issue is there's some bruxing and grinding and possible abfraction lesions. So we've got a whole sort of reasons that we need to think about why it might be happening. Look, Sam's gingiva is looking pretty healthy. He looks like he cleans it well, and I know that he has changed his technique with his brushing. So I'm not exactly sure, but we need to go through those issues before we go and restore. So I think we'd probably put some varnish on some of these teeth. This premolar, because it was the most sensitive and it's already been filled, we've got to think that, is it just the sensitivity on the buccal, or maybe there's something pulpily we need to investigate that. I often use the varnish as a bit of a diagnostic tool. I'll place it over the tooth and blow some air on it, and if that gets rid of the sensitivity, it tells me it's more of a superficial problem. If it stays even with the varnish, it tells me it's probably a deeper issue, maybe some pulpal inflammation going on. We might need to investigate further. This tooth here, there's a bit of a notch on the canine here, and I think we might restore that with a small aesthetic composite. We were talking before about the Equia Fort Fill. That's the sort of product I'd place there.
So are you talking about a composite or an aesthetic GIC?
I think an aesthetic GIC there. I mean, you could place a composite, but remember, that's all dentine. It's going to be really hard to bond to that.
Yes.
I'd get a fairly good bond to the enamel up here, but it's not in the smile line particularly. We're going to get a reasonable result, but I'm more about protecting that tooth structure and reducing the sensitivity.
We've had a question on that note. Would you ever consider laminating a Fuji 7 EP restoration with composite?
Absolutely. You can do that. One of the great things about the glass ionomer is it will bond mechanically very well to composite on top of it. My issue there is making sure that you've covered all the dentine with the glass ionomer. I'd probably suggest using the Fuji 7 EP white, not the pink one. The pink tends to show through some of the translucent composites, but very good technique to laminate your composites with, laminate your glass ionomers with composites. Just depends whether you've got enough room. You've got to have a lesion that's big enough, and certainly that sort of restoration would be definitely a good idea. I think with the sensitivity on this 5 here, we might even place a little bit of a Fuji 7 sealant over that with some varnish. With this one, I'm also, when I place the Equia Fort Fill on that, I'd probably cover that with something like the Equia Fort Fill coat. The Equia Fort coat. Reason being, that tooth's going to be in the little way of brushing, and if anything, that one's going to be more likely to be worn away quickly if we just put a thin layer on it. So,
and the Equia coat will offer better abrasion resistance?
Yeah, look, they often call it the micro-lamination technique. We just talked about overlaying composite onto glass ionomer. By using the Equia coat over the Equia Fort Fill, you are in essence doing a type of laminate restoration, composite over the top. It is a resin over the glass ionomer. It will strengthen it a lot. It will release the fluoride, it will reduce the fluoride release a little, and it's one of the reasons we don't use the Equia Fort coat over the glass ionomer when we're doing a fissure protection on an erupting molar. Erupting molars are another classic example of where you want to get some protection, where the fissures are coming through and you want them strengthened up. So I think what we're going to do now is I'll have a little look at doing some of those restorations. Now I'm going to think about this in terms of I'll do all of these in the one go. I'm not going to put some varnish on, then do the next one, put some varnish on, then restoration varnish. What I'll probably do is put a little bit of the Fuji 7 on this premolar here, and then I'll put varnish on the 5, the 4 and the lateral. And by doing that, I'll test whether that's reduced some of the sensitivity. And then when I've got the varnish on this 4, I'll see whether that's reduced that really intense sensitivity. And then I'll put the Equia Fort Fill and coat over this one here. So does that sound all right with you, Sam, there? Okay. I know we talked about this before. One of the things that is critical with these is always making sure you get the tooth surface nice and clean. I would always give these a little bit of a clean with some non-fluoride containing prophy paste. You might say, why is it non-fluoride containing? Obviously, if you're going to be etching teeth, it's difficult. I don't really have a big problem, but often the fluoride containing ones have got some oils and other things in them which sort of create a barrier and don't allow it to sort of bond to the tooth structure of the glass ionomer. Pumice and water is probably the easiest, and I've got a bit of that here today, so I might just do a little polish of that first of all, and we'll just make sure the surface is nice and clean. I mean, obviously all of these are going to be done without any local anaesthetic at all. And I'm not going to be too aggressive here, but I do want to clean that plaque and pellicle off the tooth so I can get a little bit more. I'll just get my trusty assistant to pass me the suction, and we'll just clean this out a bit. Sorry, Sam, this might be a little tiny bit cold on here. That's really good. So my next phase is to do the little Fuji 7 coat on this 2.5 here, and I'm going to start off with just a little bit of conditioning with some of the cavity conditioner, and we'll just do a short 10-second coat with the cavity conditioner. This is the 20% polyacrylic acid. So that's my 10 seconds. I usually count under my breath roughly the 10 seconds that I want. I'll just grab my suction again.
And your technique for applying the conditioner, was that to sort of agitate it, or were you scrubbing the cavity? Or?
Yeah, look, I gently agitate it. It's not like some of the bonding agents where you're really vigorously there. It really is a slow chemical dissolution, but unlike etching where if you're too aggressive you can break the enamel prisms, in this it's a milder removal of the smear layer. Now I will point out that sometimes that can make the tooth even more sensitive. In that case this tooth isn't too bad. So I'm now going to be painting the glass ionomer onto here, but when I do that I actually use a micro brush. I don't use I don't apply directly to the tooth. I'm going to get some of the glass ionomer and I'll place it on a little pad, and I'll just grab a tiny bit on my micro brush and I'll literally paint it over the tooth here. I'm going to use the Fuji 7 white here, and you can probably hear it's being mixed up in the background, ready to place. Now there are different size micro brushes, and obviously you can choose the one that's going to suit you best, and some of these are a lot bigger than others. These small little brushes here may be better to apply it, and some of these larger ones you might think are a little bit too large. I've got a bit more space here to place my thin layer of Fuji 7 on. So, you know, you can place these directly in the mouth, but what I'll find is that you get way too much. So I'm going to place a little bit on a mixing slab, and I'll just dip my brush into that. And I'm just going to come to the tooth with that. I'll place a little bit on the tooth here, and I'm literally painting that onto the surface of the tooth. Okay. So it almost becomes invisible there, but that little bit of painting on there is really all I'm doing with that. And you can probably see that that's very thin. It's just come to that gingival margin there. I will normally sort of leave that for a little moment, and as we know they start to get to that gel stage where it's a bit firmer, and I'll just get a little flat plastic instrument and just shape that up. But the next thing is I'm going to get my white varnish, my MI varnish, and I'm going to paint it all over the top of that tooth. And
that's after it's set?
Yeah, I'll wait for it to set, because if you do it too early, what's going to happen is you're going to displace it there. So I'm leaving this there, you know, a good minute or two to really go nice and hard. I think one of the problems you sometimes get with this is you feel that you've got too much excess at your gingival margin. And if you go in too early and try and play with it, you drag it away from the tooth structure. I like to leave it there till I'm sure I've got a good seal over that surface before I place the varnish on it. You can check the rest on your bench, and obviously it firms up in the mouth faster than it'll firm up on the bench. Because if you've got on your mixing slab and your room might be only 21, 22 degrees, but you've got 37 degrees in the mouth, and being a chemical set, it will set a bit firmer. I know that that's starting to go a little bit firmer on the bracket table, so I'm just going to use this instrument just to gently make sure I haven't got any excess under the gingival margin, so that's great.
Would you ever use an unfilled bonding resin or Equia coat, for example?
Yeah, I could over this. Yeah, you can certainly do that, and you can use it like a separating agent. Just be very careful that you don't use a bonding agent that contains something like a solvent or contains water, because that will actually interfere with the setting of the glass ionomer. So you just want to use straight bis GMA, something like bottle 2 of any multiple bottle system, or just straight bis GMA resin, which doesn't have any other additives on it. All right, so I'm now going to think about doing 3 things. I'm going to put some varnish over this 5, the 4, and also the lateral, and then we're going to come back and restore the 3. So we'll start off and have a look at this MI varnish. Now, hopefully I'm going to show you something that's quite interesting with the MI varnish. I'm going to use this here. Sorry, I don't know if we can get a close up of that one there, Brent. That's the one. Okay, so there's your MI varnish. When you peel the lid off this, it's quite a firm seal, but it is based on having an ethanol. I'm just going to make sure I don't dribble it on sand. It's got an ethanol base to it, so it's quite volatile. And sometimes when you take it out, you'll find it's got a little bit of separation there. So I always make sure that with my brush, I give it a good stir. Now you can see there's quite a lot of product there. I'm not going to use all of that. Even if I was doing the whole patient mouth and wiping it around, I'm probably only get halfway through that. So what I then do is, once I've mixed it, just like a paintbrush, wipe it off on the edge of the drum. And then I'm just going to apply this on the tooth, and I use the brush to spread that over the surface. That goes right down under the gingival margin, and it's a very thin coating. You can actually think about painting the surface of the tooth with this. So now I'm going to go and put some on the lateral. I'm then going to put a little bit on the premolar as well, the 4, and we'll see if that gets rid of some of that sensitivity. Now you remember before that all of these teeth were, well, the 4 and the 5 particularly, were reacting when I blew the air on, so We'll see how Sam goes this time.
We had a question earlier about whether fluoride varnishes, such as MI varnish, are safe for use during early pregnancy.
Yep.
Do you have any ideas?
I don't see any reason why they shouldn't be. There's no product inside this. This is purely the fluoride varnish. You're not going to be eating a whole lot of it. It's a fairly small amount that's coming in there. Obviously, you don't want to ingest a whole lot of it. And the fluoride that's on is a very topical application, so there's no reason why it shouldn't be placed. There's no contraindications that I'm aware of, unless, of course, there's a milk allergies. All right, so I'm just going to air thin that. I'm just going to see on this tooth here, Sam. Anything sore on that there now? Slight? Yeah, okay, so we know that there's still a bit of reaction there, so that would worry me that tooth hasn't totally become desensitised. Just like a good paint on a house, we'll put a second coat on. And it's always a good idea just to ensure, and again, it's a thin coat. I'm not putting a lot on. I may have missed a small area there. And again, this is to make sure we've covered all of the surface of the tooth.
How many coats would you put on before you call it quits, so to speak?
2, maybe 3.
2, maybe 3.
It's a bit like painting a house in a way. It's not like it's one coat does everything. Like, I think it probably really depends. And in this case, I'm really just doing a bit of a diagnostic test. How's that feel? Still sore? That's better again, yeah. I think that there may be some deeper pulpal symptoms. The fact that one's a lot more sensitive to the other, we really don't know. So I may investigate a bit further on that tooth down the track. All right, you're going all right there, Sam?
Yeah.
That's very well done. All right, we'll just finish off and quickly place a little Equiafort fill on this canine here. You can see that that's got that other lesion, and I'll show you that it's a little bit more aesthetic. Even though we've done a small lesion, I'll just dry out your poor mouth here. You've been very patient with us there, Sam. We're almost finished now. Now, I'm a big one for using cervical matrices when I'm doing restorations on these teeth. And you're probably aware there are different sorts of cervical matrices. Today I'm going to use a metal cervical matrix, mainly because I think they're really good for the glass ionomers. There are plastic ones. I'll just try and show you some of these. So these plastic cervical matrices, they're very good for composite, but what I find is when you're using them for glass ionomy, you've got to put it on and hold it there. And there's really no need for them to be clear because it's a chemical set material. Great for placing your composite. What I tend to use more are these cervical matrices. And these cervical matrices are great because you can shape them to the individual tooth. Now I'm just holding that on the end of what we call a little stick in place. These are just little director. Probably people are aware of these. They've got a little sticky end on them. The metal matrices these days are pretty hard for me to hang on to, so I like to have any tool that I can that helps me place these. So I just pick a size which I think is going to fit the tooth pretty well, and we can sort of see that that's going to sit on the tooth reasonably well there. And all I'm really done is that I'm going to go and put some more conditioner on this tooth. I'll get some of my Fuji Plus, got the wrong conditioner. We're getting some more conditioner coming in, thank you. This is the cavity conditioner again. We're going to place this all over the canine. Again, this is the 20%, so it's only 10 seconds. If you've only got the dentine conditioner, which is 10% polyacrylic acid, you use it for 20 seconds. So you just need to know that the cavity conditioner is the pale blue, the dentine conditioner is the dark blue. All right, we'll just rinse this off again. And we'll move on with that quick restoration. Thank you. So we've got a nice clean surface there. Now this time I am going to place it directly on from the gun. I'll describe a bit later, but there's actually, for some of these, if you're using Fuji 7, you actually get an extension tip, which is a really fine tip. Now you'll note that I've got that in place before I place the restoration. I like to have this in place so it's ready to go. I gently tilt it back so I've got some space. And I'll make sure that I squirt this underneath. Make sure I've activated the gun enough. Now the Equiafort fill, I'm going to take that off so you can see. The Equiafort fill is a more aesthetic material. It's less white than the Fuji 7, but that just shows where it is. I'll place this back in on the tooth. I always like to make sure that I seat that down fully. And I've hopefully got all the excess coming out. I can see that little bit of excess coming out on the incisal or occlusal aspect, so that tells me I've got enough. I'll give this back to my trusty assistant. Thank you. And I'm going to hold that there to set. Now, This is about a 2.5 minute set time, so you might want to come up with a great question while we're just letting this set before I take this off, because I don't want to drag it off too early, because it's going to drag the glass ionomer off the tooth structure. So I'm just sitting there letting that set hard at this point in time.
On that note, if you have a question you want to ask Prof Myers, take out your smartphone, open the browser on your smartphone and go to Schein.tv.
So these glass ionomers, I think there's a lot of confusion about glass ionomers and which ones to use. The reason the aqueous fort fill has come out, I think, in recent times is that while Fuji 9 was a very aesthetic material, it did tend to dissolve a little bit too rapidly, and we saw a problem with some of washout in some restorations, particularly the open sandwich restorations. So some of the newer versions are great because they've got lower solubility, yet still maintaining that high fluoride release and protection of the adjacent tooth structure. I think that, you know, when we move to the Fuji 7 type products, obviously, as I said, they're not aesthetic at all, but the higher fluoride release and uptake from things like varnish means they're going to be more effective in terms of preventing recurrent caries, preventing demineralisation and just protecting the tooth structure.
So in practice, Sam would receive a 161 in this case? Or,
yeah, as we said, this is, you know, this tooth here is almost a restoration, but I am going to probably still put that down as a surface protection. Depends on whether you need to do some tooth restoration or not. Obviously, it is still a one surface restoration, so if you feel you've done enough on this to create and call it a 521 in this instance, then so be it. Certainly this tooth back here would go under that surface sealing, the 161 code. So, you know, I can twist off that and you can see that that matrix tip wants to really stick quite firmly there, so I'll just gently peel this off. And as with all good live demonstrations, it probably won't work exactly how I want it to, but that's always what we want to see. So I'm just going to gently get under that margin and peel that off, and you can see that that gives you a pretty nice restoration there aesthetically there. You have got some scratches which I would now just trim off with this. Now obviously I want to wait 2.5 minutes for the equia. I'm just checking around the margins there that I haven't got any excess, and you find that these cervical matrices give you a pretty good margin around that, but I'll trim that up in a minute. I do like to trim these just to make sure, because you do get that excess towards the incisal, and I do trim them with normally a little abrasive disc. In this case I'm just going to use a Softlex disc in a medium, and I'm not going to run this particularly fast. Now the question is, do I do this with or without water? Being a glass ionomer, I tend not to want to contaminate, even though I'm past the moisture critical time. But I've now got that pretty smooth on that particular area there.
We now have a recent question about what's the approximate longevity of these sorts of restorations in your hands.
Look, I would have to say that most of these restorations, you know, how long is a piece of string? But it comes down to the risk of the oral environment risk there. Obviously, if this was a really healthy patient, they wouldn't have had the issues of some of the recession possibly. Well, now if they are a healthy patient, they might go on for years. Composite would probably be my choice in this particular area in a low risk, high aesthetic case. Where we've got some risk here and I want to protect it, I'm expecting these are going to last 2 to 3 years on a minimum, sometimes longer. If the acid increases, then they're going to dissolve more rapidly. If there's a lot of abrasion on that, it might break down. I'm no way going to say that these are going to last 20 years, okay? You know, on average, 3 to 5 years for a glass ionomer in this sort of location would be quite acceptable.
And what kind of, would we, in the past we've seen sort of discoloration of facial surface glass ionomers. Are we expecting similar behaviour from equia, or is that different?
Yeah, I think it's slightly different. I mean, you do get discoloration. Obviously, it's not as smooth as a nanofill composite, so you're not going to get that really smooth surface finish. So in this particular one, as you'll see in a minute, I'm going to place some of the equia fort coat over the top, which gives it that potential to have a smoother surface and protect it from breakdown over time. They will discolour, there's no doubt about it. If you lose that surface over time, you'll get some discoloration, but it's very easy to patch back. And then I'd move on to, if you've improved the patient's overall diet, lifestyle and oral health risk, then you can do that laminate restoration. You just cut this back and put some composite over the top. And so you haven't lost any time, you're just going from one restoration. You've seen that the patient's compliant, improved their oral environment, and you can move on to the composite resin. So I might just get some of that equia fort fill. Now this has to be placed directly from bottle onto brush for placement. It's a very volatile product. And I always warn the patient it's got a little bit of a horrible smell, so be prepared, Sam, it's going to have a bit of a strange smell to you. So I'm going to hold my brush here and I'll get a little bit of that placed on that. It's there, okay. And we're just going to paint this on the tooth. Now it's a very thin layer. I do rub this over the surface just to make sure it's covering everything. And you can see that that's gone down. You will get a bit of excess under the gingival tissue, so air thin that just gently, not too much. You don't want to blow it everywhere, cover the walls of your surgery. But then I need to cure this, and I cured this for quite a while. Being a very thin layer, you'd think it doesn't need much to cure it. I just need to push the right button. And a 10-second cure is probably the minimum we need to do with these bits of varnish, but sometimes I will give it a full 20-second cure to ensure it's really fully set. This light's only been set on 5 seconds, so I'm going to give it a series of 4, which will give you a very hard surface.
Going back to fluoride gels versus varnishes, we have a question about, are varnishes more effective as compared with gels or foams?
Yeah. Look, I think the thing with the gels and the foams is that they're much lower concentration. They don't have the substantivity of staying on the tooth as long as the varnish would, so the varnish is going to stay there a lot longer. And I think it creates a better reservoir. If you can get the varnish in there, I mean, you're talking 22,500 parts per million fluoride compared to some of the other gels and varnishes and foams, which might only be 10,000, half as much or even 5,000, a lot less. So, I don't have direct evidence to promote that. I think the literature shows that varnishes, and that Cochrane review shows that varnishes tend to be the most effective in reducing caries. So there we are with our final restoration. If we have a look at that, you can see that that's a pretty reasonable aesthetic restoration for the patient. We've covered the other tooth. We're going to watch what happens. I would now move the patient onto some maintenance treatment. I'm just going to pop this little retractor out for you now, Sam. You okay there?
Yeah.
You did really well. And what I would normally say is we're going to get you onto some little tooth mousse over the top of this. You're going to rub that over that for the next couple of days and keep going with that, because we need to enhance that. We'll get you with your normal brushing technique, which we've talked to you about. Put some of the tooth mousse in there, and then I would want to see you in 3 months' time, and then I'd monitor you every 3 months until I think we've got you stable, and then we can stretch it out to 6 months if necessary.
Okay.
Would you also move Sam onto a sensitive toothpaste?
Oh, look, I think a sensitive toothpaste is, again, a little bit like a masking agent. If you can't control it and you want some at-home masking, that's fine. It depends on what sort of desensitising toothpaste. I think ones that aim to create a barrier are fine. We've moved away from the ones like the potassium nitrates, which would reverse the polarity of our nerve endings and get us something which is reducing the sensitivity. What I want to try and do is create a surface barrier. So there's a lot of products out there which try and remineralise on the surface. So we might just have a quick look at that. I mean, the tooth mousse everybody's well and truly aware of, but I'm going to just run through, Sam, on how I want you to use this. Normally with the tooth mousse, you've got to think about this. It's not toothpaste. You're going to clean your teeth first, put a little bit on your finger and rub it over those areas particularly. Then run your tongue around your mouth, and that'll just create a coating everywhere. Okay. You don't need a lot of the product. With the tooth mousse, I always like the tooth mousse plus for adults. I only use tooth mousse generally with children, and we're looking at a good pea-sized amount. And just for today, I'm going to finish off by giving you a little dose over these teeth, and then we'll give you a good spit out. We don't want you to rinse this off, we just want to spit it out. I'm going to give you a little bit on the other side as well, because I noticed there are some lesions over here which we want to strengthen. And of course, I don't use trays for my tooth mousse. I want to put this on after I've got good, clean, healthy teeth. So if you want to run your tongue just around that for me, just run your tongue around your lips. Not too unpleasant to taste, that one. That's the nice strawberry flavour. All right, and I'm going to we'll let you have a spit out in a minute, but we won't do it in the middle of the broadcast, so you can just hang on to that for a second. Okay?
So for a patient who comes in for a 6-monthly check and clean, and I want to do a routine fluoride treatment, and is MI varnish a product that I can use for that?
Yeah, I think it is. I mean, I use MI varnish a lot, particularly on my older patients, and I do it routinely. So I'll give them a good descaling and cleaning. I'll talk to them about the risks, and nearly every one of these older patients with some root exposure, I will paint the varnish on. Other patients, if they're low risk, there's no reason to it. If they're keeping themselves healthy, there's no exposed root surfaces, I probably wouldn't do it for every patient. It used to be we routinely gave everybody fluoride. I mean, not everybody might need it. It's a bit like, do you fish a seal every tooth that you see? No, you work out those that are at risk and you do fissure sealant. Those that have got shallow fissures and not at risk, I mean, we're not going to be putting fissure sealants in a 50-year-old that's never had a problem. But if you've got a 50 or 60-year-old that's got a lot of root surfaces now exposed, then definitely yes, I'd do that. So you need to, again, go back to that risk assessment and work out what's happening.
Look, as I keep saying, a lot of these procedures, we talked earlier on about why do this preventive stuff, let's just get in and restore. To me, it's about building a practice. After 30 odd years of doing dentistry, what I've found is patients really love the fact that you're taking an interest in what's happening to them, bring in the preventive strategies, and they're then more accepting if you do have to do restorative treatments. And the restorative treatments last longer. So it's really all about making sure that you've got the patient on side, they tell their friends and everybody else about how good it is, and away you go.
Sounds good. And now, can you explain some more about a question here about the advantages and disadvantages of potassium nitrate as a desensitizer?
Yeah, look, potassium nitrate was used in some of the early versions of the desensitising toothpastes, and basically what it did was confuse the poor old neural endings and made them think that, no, well, I haven't got pain there anymore. It was basically reversing polarity of those nerve endings. And so rather than occluding dentine tubules, what it did was it basically created some confusion so that it didn't allow the sensation to go back. So in essence, it wasn't doing anything to enhance the structure, it was just stopping the tooth from sending the signal back to the brain. So I don't think that they're effective, and most of those are disappearing a bit, and we're going more in favour of the products that contain a range of things, whether it's ProArgin, which helps, the arginine, which helps precipitate calcium into the tubules, functionalised tricalcium phosphate, the CBP, ACP, even just hydroxyapatite ground up in some products is used there to give a calcium and fluoride reservoir. So it's aiming to create a barrier on the surface of the tooth. And those products really are more about remineralising, creating a surface barrier that way, rather than just confusing the brain and saying it's not happening, whereas it still is there. It's really about treating the root cause. And I have to say, going right back to basic principles, why is the smear layer dissolved in the first place? And it's probably to do with acids in the mouth. And again, a lot of people aren't aware of the number of acids they have. It might be because of lack of saliva, because of medications. There's a whole raft of things around that which cause changes in the oral environment. And that dissolution of the smear layer is what's going to open tubules and allow fluid flow and sensitivity.
And what are your thoughts on bicarbonate mouth rinses?
Oh, great product. I mean, I think bicarbonates are great for reducing the acidity and increase the pH. A little bit of a salty, bitter taste sometimes, and I think they're great. You can get commercial bicarbonate products which are a little bit minty flavoured, but most people have got some bicarb in their home, and they can just put a little bit, half a teaspoon, half a glass of water and rinse with that. Particularly useful if patients have a reflux or they have episodes of vomiting and a lot of acids in their mouth. It can also create a little bit more better taste sensation because you're neutralising the pH and flavours come back a little bit more. Mind you, I think anything tastes better after a rinse with bicarb, after that salty taste.
And you mentioned earlier GC dry mouth gel. One of the really well-known dry mouth ranges would be the biotine range. Yep. What are your thoughts?
Yeah, look, I think both are good. The problem I have a little bit with the biotine is great product, but it's slightly low pH. It's got a pH around about 5.5. So if you've got a patient that's already at risk of some demineralisation, lack of saliva, acid build-up, it's probably not great. I think, again, I mentioned earlier how I can use it as an adhesive for dentures. Good if you've got full dentures, but once you've got teeth, I'd rather go to something which has got a slightly higher pH. And the dry mouth gel range is sort of in the 6.5, 7 range as opposed to 5.5. Plus, I don't know if you've ever tried it, but the biotine dry is not particularly pleasant tasting. I think the flavours you get with some of the dry mouth gel are a little bit more pleasant. But I know some people really like that biotine, and I wouldn't change them if they're getting great success with it. Really, the only reason you change is if you're not getting success with a product.
I met with my GSK rep yesterday who mentioned the low pH and said that some enzyme changes have been brought in or an enzyme had been deleted. Does that make you more at ease with its
Absolutely.
pH?
I mean, look, I think there are issues around what happens with saliva and improving the qualities of saliva. It's a very complex thing, saliva. It's not just about acid bases. There are a lot of different things which help mucosa. They help break down and protect the oral environment as well. And so I don't think it's as simple as saying, here's a saliva replacement, because that's a very complex thing, saliva. It's got all sorts of wonderful things in it. So any replacement is really all about, is it going to lubricate the mouth? Is it not going to cause any damage? And previously, yes, I think that low pH was a problem in some patients. If they're going to raise the pH, change some of the enzymes, then yes, I'm a lot more comfortable about it.
You mentioned earlier that the Fuji 7 EP comes with the long precision tip.
Yeah.
In what cases would you use that?
Okay, that one particularly, I've got one here attached which we've used on a previous situation, but the Fuji 7 EP, and I might just show this down in front of Sam. Sorry about this, Sam. We're just going to use you as the focal plane so we can show this. But what we've got is these Fuji 7 nozzles. You might see you've got a little, almost like a line at the end of the tip, and that enables one of these fine application tips to be clipped on, and it just clicks on quite nicely there. So that what then happens is when you apply that, you get a very fine tip of the Fuji 7 coming out. Now I use that particularly when I'm doing a unerupted or partially erupted molar, where you've got that fissures you want to protect. You can get that good access right to the back of the mouth, and you can apply that into some fissures underneath the operculum, which might be covering that erupting molar. So I think that's a really good access device for doing that. I don't want to put a lot of it there. Other thing I haven't really mentioned is that if you are putting that on the back of the teeth, you don't really want to put the Equia Fort coat over glass ionomers on those erupting molars. You're better off using something like the cocoa butter. And the cocoa butter is one of these products that it's like the Vaselines or the things that you cover things up with to prevent moisture contamination. Cocoa butter, it smells nice, it's a lovely product to use, patients don't complain about it, and it's just for moisture protection early. One of the things with the Equia Fort coat is that it does tend to reduce the fluoride release, and what we're trying to do with the fluorides on that surface protection is have as much available to enhance that immature enamel as it's come through, to turn it from a sort of carbonated apatite to a fluorapatite and strengthen that erupting enamel. So those little tips are great, but I would suggest using the cocoa butter to cover it rather than the Equia Fort coat. We're not after strength there, we're after fluoride release. So again, it's working out what's going to work best.
And again, another question, you mentioned before abfraction lesions. If we're coming along and placing restorative materials in areas that tooth structure has struggled to weather the storm, how would we be expecting to see our restorations or root surface protections last?
Yeah, it's a really good question, that one, because I think abfraction is one of those things that people agree or don't agree on. And certainly there are flexing forces on teeth, and there's always the argument that if you're going to flex something at the gingival margin, that if it's too rigid, it's going to pop off the tooth. Now, lower modulus products which flex with the tooth are probably better. Glass ionomers have fairly firm, they're fairly rigid, so they've got a higher modulus, they do tend to fracture off. One of the advantages of that is if you place a thin layer like that surface protection with the Fuji 7, you tend not to have it fracture off, but you get fractures within that thin layer, which you can't really see, and it tends not to fall off. And we also know that even if we do get some fractures, you're still going to have a surface coating left on the tooth. So I think you've got that benefit of knowing that glass ionomers are actually cohesively weaker than the adhesive bond. So I do have issues if you want to put a large glass ionomer and you do believe there's a lot of flexing. Yes, they will pop off. Whether composites are better, I think it's got more to do with the fact that the bond is better as opposed to the sealing. And so bonding to enamel is going to be much better with a composite. And certainly some of the flowable materials with that lower flexural modulus may be more tolerant to some tooth flexing.
All right. Well, unfortunately, that's all we have time for this evening. Thanks again to Prof Myers for joining us, and to our audience for tuning in as well. I hope you've enjoyed the event, and remind you that if you haven't already done so, you can click the button below the video to register for your CPD certificate. Dentists in New Zealand can register for their CPD certificate by emailing Henry Schein. Thanks again, and see you soon on ScheinTV.